Here.
This one.
Okay. That's the pointer. Okay. I get 8 minutes. So I didn't realize this was a case-based presentation, so I had to tailor it a little bit. So I'm going to show you a couple of CHIP cases. So CHIP essentially just means complex, high-risk, indicated patients. And obviously, as part of my disclosure, I do CTOs, done it all over the world. That's kind of what I do. And this is what CHIP stands for. A lot of you guys are familiar with this, but for those that don't, it's complex, high-risk, indicated patients. So in general, if you look at PCI and what we do, this is where a lot of interventionalists are very comfortable. It's in our safe zone. As you start taking on the more complex ones, the rota, left main unprotected, and et cetera, the ones that are low hemodynamic, or that need hemodynamic support because of low EF, et cetera, they get increasingly higher risk. And then CTOs are pretty much, I think, as complex as it gets. This, unfortunately, is an undertreated population. So it can be due to anatomy, which we've talked about. It can be due to hemodynamics, or it can be just that the patient is really frail and is like 95 years old or something. So it can be patient substrate, hemodynamics, or the anatomy itself. So the myocyte doesn't really care if it's a CTO or a long diffuse lesion that's occluding or impeding flow to the myocyte. So what it cares about is it wants blood and wants oxygen. So really we need to start thinking about revascularization differently. So if there's a patient with symptoms of viable myocardium, you should favor revascularization, whether it's bypass surgery or PCI. If the answer is no, do medical therapy and optimize it. And you have to do medical therapy or OMT on top of this anyways. So anyways, let's switch gears, talk about cases. 15% EF, LAD territory is viable, prior surgical turn down. So this was not done in India, so I'm just going to start with that. LAD territory, as you can see, the EF is pretty bad. You want to do it, not do it? This is something that, when it's viable, we typically tend to do it. There's an impella that's already in place. This is the access site, so I'm just going to keep going. Antegrade was the initial approach because we had a clear target, and we were able to thankfully wire it easily without too much of a hassle. Now comes the problem. Wires across, device won't go across. So what do? Again, there are lots of options for this. The first being increasing backup. Now, none of that worked, so finally had to take it out. Rota wire wouldn't go, had to rewire it with RG3 wire. So the prior channel of the wire was enough to get the RG3 across, and we did something that's off-label, which is rota over an RG3 wire. Once that was done, balloon still didn't expand. We were now able to get a rota wire down, do a 1.5 burr, 2.0 burr, and finally get good stent balloon expansion. Now again, we have OPN in this country now, so it makes things a little bit easier after maybe a 1.25 or a 1.5 drill. So this is the final result post-stenting. I got 4.5 minutes, all right. Okay, I skipped one case. This is another case that I did in IJCTO recently with another Japanese expert in CTOs. He was the first operator. I was supposed to back scrub him. It's a CIRC CTO, as you can see there. And the patient was apparently pretty symptomatic. In fact, we did this as a live case. So long lesion, distal vessel is possibly okay in terms of a landing zone. That is that part of the vessel beyond the CTO. Collaterals, we were not sure there were any retrograde options at all, and the proximal cap was ambiguous. So it's important that with CHIP cases or CTO cases or anything complex, you really go in with a plan. Don't just go and say, okay, I'm just going to try something. If this doesn't work, I'm going to try something else. You should really think about it, study the anatomy, and go in with a clear plan. So we wanted to do antegrade wire entry with IVUS. If that didn't work, explore some retrograde options. If that didn't work, depending on if the other doctor did it or I did it, we're going to do paddle wire or ADR. So this is IVUS guided entry. You see a wire in a tiny branch. IVUS was used to identify the proximal cap. And then with IVUS, we confirmed that we did penetrate the proximal cap. And then used a dual lumen catheter to penetrate the proximal cap. And now comes the fun part. You got to actually wire it to the distal cap, right? CIRCs are always hard. Those of you that are interventionalists know that. Even a straightforward, quote unquote, straightforward CIRC is never straightforward because of the angulations. You have and it's always harder. CTOs, friends don't give friends certs for CTOs as live cases. But anyways, long time attempted by the other operator, and we just had to kind of go through his comfort zone, did multiple wires, export collaterals, nothing worked. And as you can see, after 2 hours, we were not even close to the architecture of the vessel. And in general, we come from different philosophies. A lot of the Western operators tend to knuckle. Many of the Japanese don't. But finally, at this point, we were 2 hours into it, live case transmission is over. Finally said, all right, let's knuckle. So this was, in fact, 12:26. We made the decision to knuckle, got it down. And then that's a Stingray balloon, which is a dedicated re-entry balloon. It doesn't project very well, it's a fluoro save, but you can kind of see it come to the landing zone. And this is, you can see 2 dots over that radio opaque wire, okay? So that's the balloon in 2 projections. You can kind of see it on this is the wrong projection, and the one on the right is the correct projection. And we know we are proximal to the bifurcation, but this had to be done blind because I don't know where the vessel is at this point. I just know I'm in the architecture of the vessel. So at this point, initial stick didn't work. This is the second stick, and it was actually 30 minutes after we decided to knuckle it. And that's the wire getting back in. And had to kind of do this by feel, but thankfully I was able to do this. And once we do this, exchange for a workhorse wire, because it's always safer, then put in a dual lumen catheter, rewire the other branch, confirm on IVUS that you are in the true lumen at the bifurcation. Okay, that's important because otherwise you're going to stent into the subintimal space. So that's, you just saw the wire coming in from around 12 o'clock into the true lumen. Then you will see this is subintimal, and then more proximally it's true lumen. In the interest of time, I'm going to kind of skip all this stuff. This is post-stent. Time for one more case. All right, this is kind of a fun case. So this was a occlusion of a SVG. Yep, I got it. A minute. So everything's occluded, native. So sometimes what you can do is use your graft as a conduit for actually getting through. So use an occluded graft, get it. You don't want to open an occluded graft because the long-term patency is really horrible, and it's a class 3 indication. And here is the wire getting in. This actually turned out to be a graft to the PDA and then to the circ. So you can actually kind of just do a tattoo with a microcatheter and then get in. And then wired the distal circ. And so once this was done, confirm that we have a good target, flip and go retrograde. And as you see, I don't even try to wire it. This is a knuckle going up, up, up and up, and then you start working antigrade, and then this is just traditional reverse cart where you put in a wire antigrade, balloon it, inflate the balloon with your retrograde microcatheter and a wire connected, and there's no perf. Final result of the circ, done. Okay, so conclusion slide, so just give me a minute. Demographics are changing. We need to change our mindset. We should open what is appropriate and not just what's easy. And thank you.